Hey, this is Austin Nakas here at the Moran Eye Center, and I have a case here with a patient that had a strangely dislocated IOL. This was a case I had done about 3 or 4 years ago, and I knew that it had something called dead bag syndrome, where there's no cells or scar tissue in the capsule that holds the lens, and the lens was loose in there. So I'd replaced the single piece lens with a new 3-piece lens, and I put it in the sulcus with optic capture, so the haptics are in the sulcus space above the capsule, and I put the optic uh, in the capsular bag, and I thought it looked pretty stable. And actually here it does look kind of centered, doesn't it? But there's this area there that you can see where I'm kind of reaching, and there's this stuff coming around it, and it turns out that that capsule had come loose, and it's kind of coming around the lens, and the patient was noticing it. He was having symptoms, and we know now, or I know now anyway, that in dead bag syndrome that can happen where the zonules are weak and loose. We don't know exactly why, but they're not very stable. So I decided to go ahead and bring this into the anterior chamber to stabilize it, and I put it up there above the iris, so that's a good way to stabilize it. And I decided to do a Yamane fixation here. And so this is with a ZA9003 lens, which has PMMA haptics. So I decided to go ahead and fixate it, but I went ahead and removed that dead bag or capsule left in it, and you saw me kind of pull it out there, and it looks like vitreous almost because it's just so devoid of any scar tissue or cells. But I pulled that out to send to our great pathology lab here at the Moran Eye Center, the Intermountain Pathology Lab, run by Doctors Nick Mamlis and Liliana Werner, who have seen many of these cases. And so I went ahead and fixated the first side first, and then the second side, and I use the 30 gauge TSK needles to do that. Trying to center the lens here as best as I can possible and make it look nice. And I'm cauterizing it with the low temperature cautery to make these little bulbs there. And I have to make them large enough because the PMMA bulbs tend to slip back into the eye at times. So I've got to make it large enough. And here it's kind of like not quite exactly how I want it to be. So here you can see me kind of trying to pull the bulbs out, and so you can see how difficult this can be once it's back underneath the conjunctiva, which is good in some sense because, you know, it's kind of protected there and you want it to scar in there, but not when I'm trying to grab it and redo it. So I was able to finally get it out. I had to cut some conjunctiva there, and I snipped it a little bit and kind of melted it there and put it back in, and it's looking better now. It's not 100% perfect. I do see a little space there on the nasal side. And if I had to choose, sure, I'd like it to be a little bit more nasal. Right now it's a little more temporally located. But here's the thing is when you come to these situations with these lenses, you get to this point where you say, hey, this is good but not great, and is it good enough? You know, and they have that saying, the enemy of perfect is the enemy of good. And in this case, I decided I think I'm going to leave it because it's actually pretty good and it should be well covered by the iris once it's constricted, because otherwise I'd have to basically redo this whole thing. And so I'm doing a vitrectomy here, and I'm kind of doing it behind the lens and in front of the lens and around it, because this lens is now stable, although I want to still be careful. And it's not that easy to do, but oh, there's a little air bubble. I hate those. But anyway, we go ahead and try to go around the lens and get rid of all the remaining vitreous that's around there. And if there's any capsule left, I would go ahead and take that too, because it's just not doing anything there and it can become loose again later on. And I put vitreous stain there to look around, and there's no vitreous there. And things are looking okay. Maybe there's a few, so I think I put my vitrector back in to get the little remnants. But I had only had 2 paracentesis ports for this. I didn't have to make a big main incision, a big main wound, because I didn't have to remove the lens there, and that was nice. Easier to close, less wounds, and mainly more stable during the surgery. That was it, and this patient so far is doing okay, although that's the end of the case. I just did it today, but it looked pretty good in the end, so hopefully he should do well. Thanks for listening to this case. Hope you learned something.